Hello, my name is Captain Ashley Yano, and along with some of my mentors at Fort Hood, we'd like to present a case here today. Thrombocytopenia is the second most common hematologic abnormality in pregnancy, second only to anemia. TTP, or thrombotic thrombocytopenic purpura, affects 1 in 200,000 pregnancies. Also, less than 1% of pregnancies have a severe thrombocytopenia. We'd like to present a patient with severe thrombocytopenia at term who was subsequently diagnosed with TTP. She was a 33-year-old G3P2 at 36 and 6 weeks who presented with severe range blood pressures. She was found to have headaches, right upper quadrant pain, as well as moderate peripheral edema. Her pertinent labs are on the screen. Please note that her baseline platelets were 106 prior to her presentation. There was concern about early Hellp syndrome versus superimposed preeclampsia given her untreated chronic hypertension. However, upon further investigation, she did have a history of a major blood transfusion at 18 years old, which she did not know the diagnosis for, and had an influenza infection just weeks prior to her presentation with us. Subsequent laboratory evaluation referred her an ADAMTS13 activity level, which was severely low. During her hospitalization, her platelets natered at 7. She received multiple blood transfusions, to include one intraoperatively at her C-section due to her breech presentation. She also received steroids and plasmapheresis and was ultimately discharged on hospital day 8 with platelets of 111. Our clinical question is, what is the incidence of superimposed conditions causing severe thrombocytopenia in pregnant individuals? After a literature review, there was a very broad differential for thrombocytopenia in pregnancy, which encompassed benign diseases as well as life-threatening illnesses. We focused on the thrombocytopenia differential within pregnancies, as you can see in Table 1. Evaluation and your clinical suspicious may be broken into timing of the diagnosis, which trimester, as well as severity. Regarding TTP, hallmarks of the disease is thrombocytopenia and hemolytic anemia. Other findings can be neurologic, GI, renal, or cardiac symptoms, although it's not required for the diagnosis of severely reduced ADAMTS13 activity is a hallmark of TTP. If clinical suspicion for TTP is present, there's a plasmic score that can be calculated. Once diagnosed TTP, all patients should undergo plasma exchange as well as glucocorticoids. As with our patient, this may require a multidisciplinary approach. Which brings me to my conclusions. I would like to reiterate that it is important to consider the full differential diagnosis on your evaluation of thrombocytopenia in pregnancy. I wanted to share this case because I think it's important to highlight the unique opportunity to study thrombocytopenia in pregnant and pregnant patients and manage the necessary interprofessional and interdisciplinary approaches to the care of these patients.